Good afternoon, everyone. For those that don't know me, my name is Lori Leonard. I am a professor in the chair of the Department of Global Development. And it's really a pleasure and an honor for me to introduce Dr. Phil Polakoff, who is our speaker for today. Our format today is going to be slightly different than it usually is for the seminar. I'm going to do a very brief introduction to Dr. Polakoff. He is going to take us through a short number of slides here, and then we're going to run the session as a fireside chat. So I'm going to ask him some questions and then open it up to you. So I think it will be much more interactive than these sessions typically are. Okay, so by way of introduction, Dr. Polakoff has had a very distinguished career in health and in healthcare that spans more than 45 years. He's been involved in lots of different arenas or domains in public health and in medicine, ranging from the provision of clinical services to working on product innovation, to working on policy formulation, and doing many other things. Among many honors and awards, he was previously shortlisted for the U.S. Surgeon General position. He is currently serving as the founder and the CEO of A Healthier We. You're going to hear a little bit about that today. It's a nonprofit organization dedicated to addressing critical issues of rural health. He's an affiliated scholar at the Bill Lane Center for the American West, where he's intimately involved with the Rural West Initiative, which focuses on rural health and healthcare issues. In addition to his work at that center, he is a consulting professor at Stanford's School of Medicine. He's the author of 5 books and has published more than 200 articles. He holds degrees from Cornell University. He was an undergraduate here, so he's an alum, but also from Rutgers, from Wayne State, from UC Berkeley, and from Oxford University. So we're thrilled to have him with us, even though it's virtual. And I am going to turn it over to you, Dr. Polakoff, so that you can walk us through the slides. And if you just want to cue me, I will move them as you need me to. So welcome. Welcome.
Thank you. It's sort of back to the future. 60 years ago, I started at Cornell, and here we're in the next century, and things have changed for the better and the worse and in between. So it's a real honor. It's an honor to be with Lori and the invitation extended by Lauren and the entire faculty on the Ag Quad at Cornell. I think I'm going to hire Lori to be my PR director going forward. Leaving all that curriculum vitae behind, we have a lot to cover in a very short period of time. And you're going to hear a story that's bold. I would ask all of you to reflect on the expression, think bold, start small, move fast, because I think that's the world we're in now. It's time for meaningful transformational change. So let's take a look at rural America. The next slide. This is the foundation before we get to the map of America. This goes back almost to 1948. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This is in the preamble of the World Health Organization. And keep in mind, back then, during the 30s, we had some great success stories with rural electrification. We had Title V of the Housing Act. We had a great deal of other things coming out of our federal government. We should learn from that experience, and then we move forward over the years. So over the years, whether it's health or agriculture, keep in mind a lot of rural America you'll see is more than agricultural policy, it's rural policy. Right now, only 7%, if we turn to the next slide, you can see where America's at. The good states, the bad states as far as health rankings. If you notice, the same states that are dark are the same states that have been dark for years, okay? Mainly in the South, Nevada, Wyoming, and then sneaking up all through Appalachia, which we're doing some work in right now. These are not good stories. They have the highest rate of lung cancer, heart disease, the highest rate of severe car accidents, opioid addiction, and the like. The other states are better. The New England states, parts of New York are certainly better. When we look at the demographics here, we always have had a negative tone of the West of old, white, and generally farmers oriented. Actually, farming only represents 7% of the workforce now. On the other hand, we have the beauty of amenity resorts and recreation, whether it's the ski resorts, the fly fishing resorts, or in the Canandaigua, the valley of Cayuga Lake and the Finger Lakes is absolutely beautiful, or the Hudson River Valley. So we have a lot of mixed stories. As far as the population, about 20% of our nation's population lives in rural America. But there's no one definition of rural America. Wherever you go, rural is defined differently by culture, by ethnicity, by geography, and a whole host of other factors. So if you think of Maine, you're thinking of fishing. If you're thinking of West Virginia, you're thinking of coal mining. If you're thinking of the South, you're thinking of cotton fibers. And don't forget the 3 F's: food, fibers, and fuel have been well associated with rural America. The population has been sort of stagnant, although with COVID-19, we've seen rural America got hit harder than any other place in America. There were more deaths amongst the older population there. On the other hand, we did get some growth learning about telehealth and what's the impact if it's done correctly. We also learned that we have a real gap in our public health system. And let me just put out what I call the 5 Ps now. Let me go through them slowly. There's personal health, there's population health, there's public health, there's public and political will, and they're the places we live, work, and play. And if we do it right, we're going to end up with more prosperity and health, or health and wealth. However, right now, whether you challenge me or not, that's open for all our discussion. I think in our society, we have more privilege to access to good care than it's a right. I would challenge that. I think as we move forward, it has to become more of a right. The system has to be less fragmented, more efficient, and more effective. And we also have to make sure that the different programs in our federal government are more organized. There are over 400 different programs within the federal government, fragmented throughout the place. Generally, Congress deals with the what, and the federal government, the state government, and the local government should deal with the how. How are we getting things done? Nevertheless, it's really hard, and we'll see going top down, bottom up. Next slide, Lori. So crossing the continental divides or bridging the gaps, we have to look at the past, the lessons learned, what we can do presently for change, and where we can get to the future. There was a famous physician many years ago named Sir William Owsley, who was the founder of Johns Hopkins and then went on to Oxford. His great one-liner was, a good health provider is one who treats the disease. A great health provider is one who treats the person. So I would only challenge as we go forward, we have to look at this more as we, just not I, but the personal person has to be involved. We have to define the rural-urban divide, and now they're coming together. Is actually, as urban spanning into the rural area, we now have to worry about wildfire encroachment in that area. Youth and age, more older people still reside in the rural areas. They're having problems with isolation, depression, and transportation for healthcare. Maternal and childbirth issues there are unbelievable. There are not enough places for people with pregnancy to go get their care, and that's a real challenge. The youth has a problem of, are they getting good education, bad education, and what are they doing with online education? There's some people favor online education, some people rather be at Emerson or Warren Hall on the campus at Cornell right now, interacting personally with the instructors, the professors, and on. Inequality and social justice. It's important to note that 24% of rural America now is of colored people. With that number, over 50% of Native Americans are living in distressed poverty counties, and the same thing for Black Americans. So there's a real social justice inequity thing, and it doesn't matter if it's California, the Central Valley, amongst the Hispanics, or Mississippi, Alabama, Louisiana amongst the Blacks, or the people who have migrated into Maine to deal with the oyster industry. Low tech, high tech, we're making some significant progress on broadband, but we still have places where it's really hard to see the internet taking presence. So these are just some of the gaps, and I'm putting forth that we have to bridge the gaps in a meaningful way. Next slide. So if you look at what the Robert Wood Johnson Foundation put forth several years ago, looking at social determinants, I rather think it's drivers of health. And I use the big word health because it's all about increased well-being and longevity, not simply sick care. We have action areas, creating healthier, more equitable communities, making sure that we can have actionable areas to deal with for sharing our values, fostering cross-sector collaboration to improve well-being. And we'll see that's a real challenge. To get meaningful transformational challenge, you have to have the right leadership, the right spirit, almost have spirit, hope, and energy to make things happen. You also have to make sure more different aspects. I think Cornell is a great example of an academic institution that has cross-sector collaboration. And I would only challenge all academic institutions to live up with the education process as well as the research process and put as much energy in a positive way into community service. With that, we're going to have to redefine strengthening the integration of health services and systems. If you're into the study of rural health, in the last 15 years, over 140 rural hospitals have closed down. The gap in the emergency medical service has gotten greater. The problem with community care or nursing homes is there. Most of our veterans, percentage-wise, live in rural America, so we have to address the Veterans Administration and like. If we take on the next slide, then we get to the actionable or the drivers of health. This is part of the strategic plan that hopefully many of you will engage to one extent or another to see a new future creative vision, but also deal with the real. That's an important note. People really would like to have immediate returns if they can get it, whether it's cash from the federal, the state, or the local government to help them with their food and nutrition, or to help them build out their small business or the like. So the drivers are creating more equity in their communities, be concerned about environment, but some communities have a hard time with the purity of environment. They rather hear the word recreational tourism. Social and economic environment, we really do have to look at health as well as economic development, because unless you have the appropriate structure to pay for the development from the top down, bottom up, you have the whole problem of how do you get the money from the federal government if you don't have the right staffing at a local level. If you have the problems with only volunteers or part-time elected officials, they have a very hard time working the system to get the money. And then policies and governance, which I would then put in the 3P category. How do we deal with the practicalities of change? How to deal with the policies of change? And then how do we deal with the politics of change? And keep in mind, it's, as I said before, it's more than just agricultural policy when we deal with rural America. It's much more holistic and integrated. Making health a shared value. We also have to reset our mindset and expectations. They can be lofty, but we also have to be realistic and make them applicable to today. A sense of community, and there are many different definitions of community. You have your community in Ithaca, in the town, up the live slope, out to the new campus. You have the one playing athletics, that's a community. You have a community of Cayuga County. You have faith communities, all that. So across the country, there are many different definitions of community, but each one can be worked with and collaborate to make things happen. Civic engagement, I think all of us should be involved in civics. As a physician who wore a white coat for many years, I think it's equally as important that I take my white coat off and serve my community as another citizen, whether on the school board, the developmental board, or the like. Drivers, how can we have meaningful partnerships, both in number and quality? As I stated before, how do we have cross-sector collaboration? And then we move to the care issues access to care, consumer experience, balance and integration. And we'll see on another slide coming up what I consider the quadruple aim of health. Next slide. Here we go. The next slide's right here. Thank you, Lori. Quadruple aim. How do we define better care? I think it goes way beyond just sick care. I think it goes just beyond physical care. I think it crosses the horizontal, so it's not just up the vertical for knee pain or back pain or a mole on your skin. Better health, much more holistic, lower costs. We're spending a lot of money. For those who might not know it, 18 to 20% of the gross domestic product in the United States is spent on healthcare costs. What we're paying for pharmaceuticals sometimes is off the wall. And on an international basis, because rural health and global health do interface, we are now 14th in the developing countries as far as quality of care, as far as morbidity and mortality. I think we can do a lot better. And just think about, is consumer care meeting your needs? And in the last 30 years, we've had managed care, consumer care, AI, intellectual curiosity or impact now. And with technology, we've had some great success stories, but we've had some great challenges. So we have to look in an analytical way, both qualitatively and quantitatively, what's worked. And there was a venture capitalist, John Doerr, put out what he called the OKRs. Can you define your objectives clearly? And what are the metrics for the key results? So I think that's really important as we go forward. We're almost to the most important part of this session, is the interaction between the participants and whatever I can contribute to the growth experience. Next slide. So this came out of a seminar I was with last week at the National Academy of Science, Medicine, and Engineering. And people say we have to think about grassroots, what comes from the ground up, which is very much appropriate to Cornell and the School of Agriculture, and grass tops, what comes down from the federal government, what comes down from the state of New York or thereabouts, what goes into extension in the New York State or beyond, and where it gets down to the community level and then to the individual level. So we have to look at this as a healthy community, and you can see all the little bit parts that go into the ecosystem for a healthy community. And then we also have to look at what the regulations are going forward and what the statutes are. And that goes across a whole bunch of issues. The newest now is banking, it could be in gun violence and the like. So there's no shortage of needs for meaningful bipartisan change to come forth sooner than later. As we go forth to the next slide, I would say these are the 5 C's now. We're doing the first, we're convening. Hopefully we're connecting. The communication, you can judge me on whether I'm getting to you or not. Collaboration going forward, because I told Lori in the global development, this is just the start. I think what you're doing is great. And how do we commit to meaningful change, both on campus, online, and in the community? So with that, I do believe we're going to be able to have meaningful, positive, transformational change, not all at once, but it's going to make it a better society for all. And this is the last slide is a quote that I've used over the last couple of years. In these times, if I is replaced with we, even illness becomes wellness. We can only work towards a healthier rural America together, or a better globe together. So it's going to have more interaction with, a sense of purpose and passion. So with that, Lori, I turn it back to you.
Thank you very much. That was fantastic. So I get the privilege of asking the first questions, but we will open it up so everyone has a chance to do that. And I wanted to start with a couple of sort of biographical ones. One is, I mentioned in the introduction that you were an undergraduate here at Cornell, and I know you were in CALS, and you were in what used to be the Department of Rural Sociology. And I wonder which is no longer rural sociology, it became development sociology, and it's now global development, which we're very proud of. So I wonder if you could just talk a little bit about why you came to CALS and how you decided to major in what was then rural sociology.
Yes, I'm the product of 2 immigrant parents. I'm first generation. Ironically, or sad, My father was born in Shmolovitz in Ukraine, and my mother was born in Minsk in Belarus. They came to the States and they grew up in the metropolitan New York area. My father had the privilege of going to Cornell Ag, and I guess I could be fully trusted and transparent. I was accepted at Cornell the day I was born. I did not have I did not have a choice of where I was going to go to school. That's all well and good, and I'm proud of my background. Then I decided, and this is another truth and transparency, that I wanted to be a veterinarian. And at that time, I wanted to be a large animal vet for the Ringling Brothers and Barnum Bailey Circus. Well, I had to work on a farm, and I just didn't do too well on my first experience working on a farm in Armenia, New York. But I got to Cornell and I thought, well, maybe I should start in doing something to get me into the vet school. So I chose as my initial major, botany. The guy was terrific, the professor of botany back there. But after a while, I realized that I wasn't the star in chemistry and the like. Over the couple of years, I did better. And then I migrated into the thought about becoming a physician. And Cornell set me on the road. Took me a little longer to get in, but I went to Cornell when I was 16, which was a little too young. And then I went on to get an engineering degree from Rutgers. And then I went on to Wayne State, where I entered there the day of the race riots of 1966. So it's been a full life, challenging, but Cornell is basically the foundation for what I did. And now, believe it or not, 60 years later, I'm no longer in rural sociology. I'm in global development.
And we're happy about that. One other sort of biographical question. You trained, you mentioned just now, as an MD. You also have, and I didn't say this in the introduction, but you have a master's degree in public health. I know we have a lot of students who are interested in medicine and also in public health who are in CALS. And I wonder how you use both sets of those skills, one sort of clinical and one more sort of population or public health based in your work in rural health today.
Boy, you're asking a loaded questions. The one thing I won't give credit to Cornell for, although they were part of the equation, I'll give it to Oxford. At Oxford, they always said, the question is better than the answer. So as I'm trying to give you the answers, it's a little challenging. I spent the 60s heavily as a student, even at Cornell, but not at Willard Straight, as an activist. I dealt with the civil rights issue. I dealt with the war in Vietnam. And then from there, I trained at San Francisco General. And from San Francisco General, I went on to become a commissioned officer in the U.S. Public Health Service with the CDC, with NIOSH, the National Institute for Occupational Safety and Health. And I got to travel throughout the entire country. It didn't matter if it was Pine Island, New York, in the farm issues there, or West Virginia in Morgantown, associated with the Appalachian Laboratory for Respiratory Disease, into California, on and on and on. And I saw there was a real interface between public health and clinical care. But as I grew older, I saw that they're in separate silos. Everything has a vertical silo and not. And back when I started in public health, it held high esteem in the state of California, the CDC. I wouldn't say it needs a little bit of rebranding. It needs a lot, because during COVID-19, public trust in the public health messaging was challenged. Many of the local public health departments, which had been 3 counties merged into one, separated, and the politicians took over public health. So I think we got a great opportunity to go forward where it's made much more practical. They get more in policy. And clinical medicine, I guess I'm challenged. I think going to see a physician, a nurse practitioner, a physical therapist, it doesn't matter who, a mental health specialist, I'd like to have the person look me in the face and smile a little bit, rather than just sit at the computer pad going boom, 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 boom. And also, I'd like them to have a follow-up. I just think there's a great opportunity. The emergency medical service has to be responsive to the needs, so you can't sit and wait. So, I mean, I'm caught between when I was an emergency room physician dealing with your immediate needs, as well as the long-term care, which has different aspects. So to answer your question really specifically, there's a total hybrid, and it goes just between public health and clinical medicine. I guess the area that I'm putting most of my energy into now, with a little bit of permission from you to say it, is into communications. I think right now, how you interface with people so you can bring people together and have them listen for more than what I'm talking is a great success story. So apropos of that, we just did a story podcast, which hopefully you'll see shortly, called Three Young Men, the Pep Talk. And on this, we're going to talk about three areas that are all integrated: education, communications, and health. And the reason why we're calling it the Pep Talk is these are three older men. One's named Phil, one's named Elliot, and one's named Paul. So that's the reason for the Pep Talk.
That's great. Let me transition a little bit into talking about rural health. I wonder if you could tell us a little bit about what you think is particular or special about rural communities and the health needs or the health conditions in those parts of the country. So, why is your focus at this stage in your career, maybe even earlier in your career, why is it on rural communities and rural health? I think you said a little bit about that with the slides, but maybe if you could expand a bit, that would be great.
Thank you. Well, I think there's a loop. I think I started in agriculture. I think I worked in NIAS, traveling around the country, all over, seeing America, and as well as overseas. Recently was in India and Botswana and other foreign countries, and seeing that they have similar problems with similar issues. And then I worked in all the different sectors of healthcare, the academic sector. I was on the faculty of different entities. I gave speeches in this country and overseas. And then when I was shortlisted, I did not get to be U.S. Surgeon General, and I really felt that was critically important to be able to speak so everyone could hear and also contribute to the dialogue rather than just bureaucratic or hierarchical. Stanford asked me to come onto their faculty, and we did our first major project in Santa Fe, New Mexico, and they had some significant problems in Santa Fe. It's a poor country, high alcoholism, beautiful country. I mean, it's just gorgeous if you haven't been there. Santa Fe is a marvelous place to visit. And we brought together people there. From there, I then went in to do a major project in Salt Lake City called, and that's why you see the Healthier Rural West. And we brought together people from all parts of the West to talk about different social issues, from crime and justice to food and nutrition and the like. And as I got into this, I got to see that change is really challenging. And the person who has as his mantra or as his brand, I believe at this stage in my life, I'm a passionate disruptor with definable purpose to get things done. So that's when we took on the issue to change, and we've seen the experience. It's been really exciting. However, day by day, it's not always easy. And we're about to do a major session filming another documentary. Last year, we filmed a documentary, which you can see if you're LinkedIn, or I'm sure Lori can get you, on Las Vegas, New Mexico, which was the predecessor of Las Vegas, Nevada, believe it or not. And now we're going into two counties that I dare say, think about. If you know Mingo County and Pike County, if you don't know where they're at, I'm sure you've heard the words of Hatfields and McCoys. So that's where we're going in. And we're looking to create a bi-county task force for them to have a healthier living and well-being. So does that help, Lori?
That's super helpful. I'm going to ask just a couple more questions. We have till 1:15, is that right? Okay. So let me ask a couple more questions before we open it up to the audience. You shared with us WHO's very holistic definition of health. I wonder if you could talk a little bit about what you think the biggest impediments to adopting a more preventative, a more holistic approach to health in this country might be.
Do I have your permission to be slightly humorous?
Yes, please. We like humor.
I think it all boils down to three words: money and me.
Hmm.
I think everyone's concerned that their vertical silo, it doesn't matter where you're at. If you're in the pharmaceutical industry, look at all the ads. I'm not saying they did a good job with the vaccine of Moderna and Pfizer and how much they're pushing Paxlovid and other drugs now. I can tell you it doesn't go into hospitals. They're merging with health plans on medical advantage for the elder people. What does it mean? States that aren't giving Medicaid to everyone. Tompkins County Hospital versus another hospital. Are they merging? I did something with Intermountain Hospital System, and they're merged with another one in Colorado. So where is the leadership? What's the relationship between the CEO of a hospital and the chief medical officer? Where does leadership come from there? Where does the community come into? Where does the community health clinic? What about the federal qualified health clinics? Where do they fit into it? So I'm just saying, I think sometimes people don't take a pause, reflect of where they're at, be fair with a qualitative and quantitative analysis. What I would call, and for the other students, it used to be known as the SWOT analysis. I'm sure Lori's very familiar with that word. I changed it to the Scott analysis. I said, what are your strengths? What are your challenges? What are your opportunities? And what are your threats? Where does entrepreneurship and capitalism fit in with social justice? I just think we have to have a more open-minded discussion where we can disagree, but we don't have to be disagreeable. And we can be intellectually challenging one another to say, where does physical, mental, and social well-being merge together? So that's where the World Health Organization, I think, was a phenomenal thing. I actually wanted to add one word to it. I tried to work with the UN on this one word. So they state is health is a state of complete physical, mental, and social well-being. I tried to insert the word spiritual, not religion, but spiritual, because I think that has an impact on everyone's well-being. They wouldn't let me do it. They said it was too political. So be it. Not everything, failure is okay. I actually have no problems with the word no. Have a harder time with the word maybe. And I do like yeses. So when Lori said, be here, I had to cut a deal with Lori of doing it on a Zoom, but I did promise her I'd get to Ithaca sooner than later.
Yes, and we got a yes from you, which made me very happy. All right, let me ask one more. So are there examples that you can think of communities in the US that are experimenting with new approaches to health promotion? I mean, you mentioned the two counties that you're working with in West Virginia and Kentucky, or examples of communities, even if you're not working in them, that have really innovated in terms of providing preventative care or more holistic care in ways that you find notable. And I wonder if you could talk a little bit about them and what they're doing.
Yeah, that's a great question. I think from some of you, the basis of that would be the blue zones. If any of you can ask the question, how many of you've heard of blue zones? Blue zones are communities that have had extended life and longevity. Reading, Pennsylvania, which is a poor area of Pennsylvania, has had great success. And it turned out when they did what Malcolm Caldwell did a book on it, and he found out the reason why was very simple. All the people in this community had similar roots of origin from Italy. So as they got older, there was such a sense of community and worked extremely well. Another place, which is interesting name, is Cuba, New Mexico. And they had the primary care doctor start to teach community health workers, and they went out and opened up paths, hiking paths and other ways of eating. And it's turned out to be a great story. You can see along the Columbia River between Washington and Oregon, they've done the same thing with better nutrition and more exercising. There are many other places. There are places in the Olympic Peninsula in Washington where the hospital has set up a health center. The one I'm very impressed with is where we're going to in Williamson, West Virginia, the Williamson Health and Wellness Center, where they've taken the community and taken a small clinic and then merging it with a local hospital, and now it's setting up food banks and farmers markets. So there's a lot of very good stories. I'm sure there's some stories very close to Ithaca where with all the agriculture place. Actually, my family was heavily involved in agriculture because they used to own Goldfield champagne in Hammondsport, which I was very fond of. So yeah, I'm sure every place has a story. The question is, how do you amp it up and how do you amplify it so it interfaces with those who need care today in one way or another? But there's no shortage. I will tell you, though, the flip side of that, it's very hard to find what I call empathetic, data-driven success stories that are in media, where the story is told that it's not only about the problem, but it shares the solutions. And that's where a lot of my passion is tell stories no matter where it is. We're going to do a film in Sonoma County in New York, looking at the Native Americans there. We're also looking potentially into Colorado, where 30 rural hospitals have set up the Western Healthcare Alliance, where they're pushing a lot of energy into promotion, health promotion and wellness. So, Lori, there are a lot of good stories. I think we can just tell the stories, and the national organizations that represent rural America can do a little bit better, whether it's the philanthropic organizations or the National Professional Association. I think they can tell their story a little clearer to give more hope, spirit, and energy to those trying to become the new leadership of this field.
That's fantastic. That's really, really interesting. Ed, do we want to get a couple of audience questions? And then I have a couple more after students have had a chance to ask. Ed has the microphone. Put your hand up if you'd like to ask a question.
Ready?
Don't be shy.
May I ask it?
There.
Thank you so much. I really appreciate so much of what you had to say. The kind of language that you use around just dribbling down, and all the time you were talking different kind of frameworks and paradigms and catchy phrases that you use that caught my attention and made me remember the example you were giving of time. And I'm really curious how much that is language is part of your transformational change strategy. If it just sort of comes natural to you and you do it when you're in a group like this, or is this a deliberate part of how you try to tell stories and help people join the transformational change, I'll call them movements that you're leading?
What a great question. It's not a simple response. I think by going through, there's a Yiddish word called spilkes, which means ants in your pants. I've kept looking at society in a holistic way. It actually started with Amos Hawley, well-known in rural sociology many years ago. And when you get there, that one quote I gave you about the I to the we, I had to make some transformations myself. I ran for public office at a young age. At the age of 32, I ran for lieutenant governor of California. And to be honest with you, my New York sense of humor didn't go well in California. So I had to have 2 California cosmetic makeovers to play to the people here. I learned over the years that I talked too much and I didn't listen. As you get older people tend to talk too much and don't listen to what other people have to say, of different ages, different ethnicities, different gender orientations. So you have to listen. And then I learned that to capture attention, less is more. So I think your question answered itself. It was both deliberative, because I knew Lori would be judging me on this one. I practiced for this. It wasn't just extemporaneous. To be honest with you, I would rather be in person with you, knowing who you are, rather than hearing Lori give my bio again. That I'm getting tired of. I'd rather hear, I know Lori's bio, and if you don't know it, she went to undergraduate at St. Olaf's College.
Not about me. Not about me, Phil. Thank you.
Thank you for your question.
That was a great question.
Yeah, thank you very much for such a fantastic presentation. My name is Ed Mabai in Global Development. And my question is this, as somebody who is both familiar with the rural US and still the global South around the world, the similarities are quite reminiscent here. I wonder what lessons you think America can learn from the global South, other countries, in terms of public health, and vice versa as well.
Boy, great question. Might I ask you where you're from?
From Zimbabwe.
Okay. Well, many years ago, just to make it home, when I was at Oxford, I was going to go to Zambia, which is not that far away from Zimbabwe. And you'll never know why I wanted there. I wanted to study the chronic effects of marijuana. And in East Africa. And James Lawless, the head of the Flying Doctors, invited me to come. But then he said I couldn't do a pilot project there because there was too many variables. I couldn't get a community that was, whatever you want to call it, a study group to go against the ones who smoked because there was too much interfacing. As I've traveled around the world, they've all had their issues. I was in the Soviet Union before it became Russia, and I saw the same issues. So public health and the World Health Organization is looking for its identity as long as the UN. So we really got a real issues around the world. I think we can sell some success stories and bridge people together. So we have to get them to come together. In Botswana, where I was last year, what they did in the Okavango Delta was unbelievably gorgeous, but I didn't get the feeling towards the people there who needed better health, better care, and better education as much as the US was going to give them money for their environment. So I'm looking for bridges, as I mentioned before, bridging the gaps. I think we got bridging the gaps. At Cornell, when I was there, we had a great group of people from other countries in attendance. I learned as much from them. I remember many from Ethiopia, and they were in their issues with the Eritrea going into that period of time. So to answer your question specifically, we have to have some forums that people can interact. And I think, to be candid, I'm here's pitched, I think just where you're at now, I would say Cornell and global development, since it's no longer just rural, now it's bridges. And when I gave the speech to the Rhodes Scholars at Oxford, that was exactly the speech I gave to the Rhodes Scholars there. How do we bridge the gap between rural and global? So I think you're onto something very important.
Any other question in the audience? Of course, about communication, about education, about public health, about medicine. There we go.
Thank you so much for your presentation.
Hold it right to your mouth.
You talked about public health sort of needing a rebranding because of like sort of loss of trust during COVID, and also like I guess you talk about collaboration, but also how do you sort of keep the balance of like politics not getting involved too much with like public health and science, but while working together, and also like what's like the best way to begin to like sort of have the trust, the public having trust in public health. Yeah, so like those are my kind of two questions.
Well, that's once again, boy, Lori, I wish I was there. Your questions from your students or your faculty are just superb. I would go back to the original line I gave you at the beginning, and you're welcome to steal all the lines and use them in any way you want. I think we have to think bold. So if we think bold, going back to the World Health Organization's definition of health, I think it's pretty holistic. You know, I would just submit the word spiritual in it because that attracts a very big audience. But we have to think about physical, mental, and social well-being. We're not doing justice to mental health in this country. It's just not there. For any of you know anything about mental health, my father, towards the latter years of his career, worked for the VA hospital in Montrose, New York. And their mental health was a major issue, was the switch on of medication to schizophrenia. But there are other ways to treat mental illness than drugs. Two, we have to look at the leadership. So I will tell you, I'd like to see more action. And I'm not talking about Cornell versus any other place. I gave a speech this year at the American Public Health Association, and all the schools in public health were there and had their booths there. All well and good, great. I didn't see what they were doing in the communities that they were selling. They were selling coming to school. I'd rather see them show projects of action, not just what's on campus. Do an internship, get yourself mentorship. We're doing that in high school education through big picture learning now, where they have ways of students finding the mentors, both in an academic institution and in the technical skills area. So I just think there's ways that we have to think about how to educate going forward to the next generation. And I guess on this one, I would say it's okay to be 21st century oriented and not stuck in the status quo of the 20th century, but learn from the experiences. And coming out of Silicon Valley and Stanford, not everything you do is going to be a success story. So be available to being on the edge a little bit in what you want to do, but have laser focus. For the person who asked the last question, I think I tried to do too many things at the same time, and I would have gotten more success, laser focus. And let me give you one specific success story. In the 1970s, I did a major project with the help of the US government, National Cancer Institute, National Institute of Environmental Health Sciences, OSHA, NIOSH, and the rest. And we screened 15,000 shipyard workers, Rosie the riveters, Sam the ship fitters of all ethnicity in the Bay Area who were exposed to asbestos. And we did screening, we did education, we did media, we did national testifying in Congress, we did some stuff on with major federal organizations. We had the support of the Secretary of HHS. And I think that's, since Lori asked for a success story, I think we were laser focused on a problem. The only thing is I think we overstated the adverse effects of asbestos in causing pleural plaques, and not saying, I think we made an association that anyone who had a pleural plaque also would have lung cancer. That's not true. It was just a hallmark of exposure to asbestos. It told you that be sensitive to a higher risk, but it didn't mean that. But it was a great learning experience. And I think that set the foundation for a not-for-profit institute we set up. So I think if you really want to do things, find the team of players, make sure people have their skill sets, make sure that public health promotes itself with more best practice success stories, have more voices. I think the voice who dealt with our COVID is a phenomenal person, but I think he was challenged by the politics. Anthony Fauci, who, by the way, went to Cornell Med School, and by the way, he was a sponsor when I was trying to be team Surgeon General. So I think he's just a unique person in the public sector.
Fantastic. We've got only 2 minutes left. So unless there's a pressing question, I think, okay, we have one more.
Thank you so much for your presentation. I just have a real quick question about the digital health. You were thinking, what's your opinion about the connection between the digital health and the public health? And do you think, is there any possibility or opportunities to combine the current medical education with the digital health development? Will it push the medical industry quality or something like that?
Oof. Last question with 30 seconds to answer. I'm a great fan of digital health technology. I'm not so sure I'm a fan of 100,000 apps in health, okay? I'm not so sure I'm a fact that telemedicine or telehealth or whatever else always has a checks and balance on it. There's some scamming that's going on in it. There's if you never know the physician or the healthcare provider, whoever they may be, can you really trust them? I really do find it's best to get references on something rather than just doing a Zoom with someone looking at a pimple, because I've seen malpractice of a second opinion. I, per se, I'm not the healthiest person. I have some issues, whether it's one or the other. I'd like to have making sure I know what's going on. And if you go to the websites, you get all the information, you get digital information. Data is important. We got to get better health data, more trusted, more holistic. The CDC can't even get the data from many of the states. The hospitals don't want to give it. The health plans don't want to get it. So somehow Washington, where you have standards and regulations has to be a little bit more specific and not just cater to the local needs for the moment, whoever's the elected official. There really has to be much more nonpartisan, bipartisan ways to think about what the what is, so we can get to more of the hows. And I do believe digital is going to play a major role, but it's not the total solution. It's a meaningful part of the solution.
Okay, great. Students and colleagues, thank you very much for the fantastic questions. And particularly huge thank you to Dr. Phil Polakoff for spending an hour with us today. It was a privilege to have you. It's really good to see you. And I hope we talk again soon.
Thank you.
Thanks for joining us.